Hi everyone. I wanted to talk to you about hyperthyroidism today. Hyperthyroidism is fairly common in older cats. It's typically caused by a benign thyroid tumor. Rarely we're dealing with a malignant tumor, at least when these cats are initially diagnosed. The thyroid glands are located in the neck, and they're responsible for a number of things throughout the body. One of them is control of metabolism. And that's why one of the main symptoms that we see in cats with hyperthyroidism is that they'll have weight loss despite a ravenous appetite. So metabolism increases, they need to use more energy, and they'll try to eat more to compensate for that, but they'll still lose weight despite a ravenous appetite. Sometimes you'll see things like vomiting, increased drinking and urination. On blood work, you may see increases in liver enzymes, but from a symptom standpoint, weight loss despite a ravenous appetite is by far the most common one. Vocalization, irritability, sometimes even aggression can also be seen. Cats becoming more clingy as well. One of the other things that thyroid hormones will do is they will increase the heart's contractility and the speed in which it contracts. So the heart beats faster and stronger, and as it beats faster and stronger, at least initially, it sends more blood to the rest of the organs, including the kidneys. So one of the things that we always talk about is how hyperthyroidism can mask kidney disease. So because this happens more commonly in older cats are more likely to have chronic kidney disease. And the bottom line is that you just can't trust your kidney values when you have a patient that's hyperthyroid until you correct the hyperthyroidism. As the heart beats faster and sends more blood to the rest of the organs, blood pressure can increase as well. So it's important to measure blood pressure in these guys. As the heart beats faster and stronger, because the heart is made out of muscle, it's like the heart went on a weightlifting program. So the walls of the heart, they tend to get thicker as well. And the chamber ends up becoming smaller because the heart is needing to pump more, but it's not pumping more if your chamber is smaller. Eventually, you could develop a condition called hypertrophic cardiomyopathy that can occur with or without hyperthyroidism, but it can lead to heart failure if it is allowed to progress over time. So obviously, you can't leave a patient that is hyperthyroid without treatment. When we talk about treatment options, if your eye had hyperthyroidism, we would receive I-131 therapy. That's the gold standard treatment for hyperthyroidism. Because of the fact that I-131 was not widely available, methimazole sort of became a common form of treating these cats. And methimazole is a medication that it prevents the thyroid gland from over-secreting thyroid hormone. The key is that methimazole will not treat the tumor. So your tumor continues to grow, but it's not secreting as much T4. And at the end of the day, if your cat lives long enough, methimazole will eventually stop working. And it will eventually stop working because the tumor gets so big that there's not enough methimazole in this world to take care of controlling the hypersecretion associated with that tumor. And in fact, when we look at chances of having a thyroid carcinoma when you're initially diagnosed is like 0.4%. But if you've been hyperthyroid for 4.5 years or longer, that increases to 20%. And it keeps increasing over time. And the thought is that just like with anything, as these tumors grow, they have a higher chance of becoming malignant. Methimazole is only used in humans to treat patients that can't undergo either surgery or I-131 therapy. So it's not considered a treatment for hyperthyroidism. It's only a treatment when you don't have the option of doing what's best for the patient, which is to address the tumor. The challenge with surgery in our patients is that if you have unilateral tumor and you remove that thyroid gland, not a big deal. But if you have bilateral hyperthyroidism, one, if you remove both glands, you're going to make your patient hypothyroid. Oftentimes, the parathyroid gland that controls calcium is removed with it as well, so less than ideal scenario. And also, if you have ectopic tissue, not just a thyroid adenoma, but any tissue that's secreting thyroid hormones that can be anywhere in the neck, all the way down to the base of the heart, surgery is not going to address that. This is the example here. You have a thyroid nodule, but then you also have ectopic tissue, and that's not going to be addressed by surgery. It will be addressed by I-131. I-131 is really non-invasive. It's basically an injection under the skin, water that's mixed with iodine that's radioactive. So it's not a medication where you can get reactions from. The biggest downside of I-131 is the fact that you're making the patient radioactive. Very different in human medicine, where if a human is treated with I-131, they're going to get 100 times the dose that a cat would get. The difference is that when they made the laws in veterinary medicine, they made them in a way where pets could not be a source of radiation to humans. So the biggest downside of I-131 is all the hassle associated with protecting yourself from being exposed to radiation, which I actually think is a great thing, right? You don't want to be exposed to radiation if you don't have to. And so these physicists did this sort of backwards calculation to figure out, okay, so how much contact can you have with that patient without receiving more than what we call background radiation? Because we all have a cumulative radiation dose throughout our lifetime, and we just don't want your pet to be part of your cumulative radiation dose. So that's the biggest downside, and we'll talk more about what you do at home. In terms of the treatment itself, it's really not invasive. So after they're treated, we're basically waiting until their radiation is low enough for them to go home. When we talk about treatment doses, however, things have changed dramatically over the years. When I-131 was first used in veterinary medicine, these doses were extrapolated from human medicine, and over the years, a lot of people have dedicated a lot of their careers into trying to figure out how to dose these cats. There's been a number of ways of doing that. So ranging from dosing the I-131 based on body weight, based on T4 level, based on tumor volume, based on contrast uptake to the thyroid gland, and also doing a fixed dose. When we first started treating I-131, the goal was really to make these cats no longer hyperthyroid. We really didn't care much about making them hypothyroid, because the thought was that unless they were symptomatic for their hypothyroidism, and symptoms range from excessive weight gain, excessive lethargy, and skin problems, you'd ignore a low T4 after treatment. But a few years ago, there was a study that came out that looked at cats with chronic kidney disease and divided these cats into two groups. A group of cats with kidney disease and a normal thyroid function, and a group with cats that had kidney disease and a decreased thyroid function. And they noticed that the group of cats with kidney disease and a low thyroid function had a shorter survival. And the thought behind that is that just like your heart beats faster and stronger when you're hyperthyroid, and thus sends more blood to the rest of the organs, including the kidneys, when you're hypothyroid, the heart just doesn't beat as fast or as strong as it normally would. And thus, it won't send as much blood to the rest of the organs, including the kidneys. If your kidneys are already struggling, and now they're getting less blood, then that worsened things. After that study came out, it really opened our eyes to, one, let's try to not make these cats hypothyroid, but equally important, let's not ignore if they become hypothyroid. We need to address that and treat them. Mark Peterson, who's dedicated his entire career to treating hyperthyroid cats, he decided to take sort of the human medicine approach, because you see more and more of these hypothyroid cats. And in fact, with conventional doses of I-131, hypothyroidism occurs in 70 up to 80% of these cats. And what he did was, let's try to characterize the hyperthyroidism for all we can. So let's create a dose based on their T4. Let's create a separate dose based on the T3 because malignant tissue tends to accumulate more T3. Let's create a dose based on the tumor volume and a dose based on the contrast uptake. And remember that this had been done in the past, but the problem was that this was done in isolation. So people would try to develop a dose based on T4 or based on tumor volume. And when used by itself, it didn't work for all patients. And it kind of makes sense if you think about it, because these tumors don't have a linear progression. Like if you have a small tumor, small production, big tumor, big production, it's everywhere. And being everywhere within that spectrum, you really need to characterize these tumors for all the different characteristics that they have. And so with that, the dose was really based on all these different parameters. And so the individual dose will be based on the average of those different considerations. But he went a step further because the kill effect of the I-131 has to do with contact time within the thyroid glands. There are some cats that have this great ability to get rid of the I-131 quickly, and then there are other cats where their thyroid glands have a hard time getting rid of the I-131. So if you have decreased contact time, meaning the I-131 gets excreted quickly through the thyroid gland, you're not going to have as much contact time and your treatment is not going to be as effective. And on the flip side, if the I-131 doesn't leave the glands and it stays there, then you're over-treating these cats. And the only way for you to know this is by doing a 24-hour I-131 uptake. And what you do is you give a small dose of I-131, then 24 hours later, you see how much of that I-131 is still in the thyroid gland. And you know that normal cats will have somewhere between 18 and 22% of the I-131 still there. And you account for decay as well, because you know that some of the I-131 is going to get dissipated just by the fact that time has passed. So we have a standard dose or with a vial with a known amount of I-131 that we use to take that decay into consideration. And that has really changed things, because myself, that has sort of lived through the era of sort of empirical dosing, what I've really seen, I've seen cats with fairly low T4s and low tumor volumes and low contrast uptake, but with very high thyroid excretion of I-131, meaning low percentage of the 24-hour I-131 uptake. And then those cats are going to need a much higher dose than a cat with a higher T4, higher tumor volume, higher contrast uptake that has a high 24-hour I-131 uptake, meaning a decreased excretion of that I-131. That makes a tremendous difference. If you don't take that into account, you're just guessing. You're either going to be overdosing or underdosing a number of patients. That patient that had a normal uptake, it's okay, but there are many, many of these cats that don't have a normal uptake, either too high or too low. And then you're just guessing. And the other really important aspect of this is that the more we look into hypothyroidism post I-131, and this is no different in cats that are receiving methimazole, right? All that matters is if I overtreat a cat with either methimazole or I-131 and make them hypothyroid, I'm going to decrease cardiac output and make them more likely to be azotemic. And in fact, when we look at the study that was done by Mark Peterson, the percentage of cats that we actually unmasked kidney disease was only 14%, as long as their thyroid function was normal after treatment. And that means both a normal T4 and a TSH. They were euthyroid. But if they had a normal T4 and an increased TSH, then 39% of these cats were azotemic. And if you had both a low T4 and a high TSH, 71, almost 72% of these cats were azotemic. So unlike the 15%, which is what you expect to see, 15% of the population that has azotemia, if we go from the 14% to the 39% and certainly to the 72%, that difference is man-made. That difference is not because we unmask kidney disease like we used to think before, that you're just, oh, that kidney disease existed before, we've just unmasked it. It was always there. So now we know that that's not the case. So if you see a patient that is azotemic, and if their T4s are normal, but you haven't measured TSH, measure TSH. And if the TSH is increased, you got to treat that cat. And by doing this individualized dosing, you decrease your chances of hypothyroidism from 70 to 80% to 3% of overt hypothyroidism, where you have an increased T4 and TSH. You go from 70 to 80% to 3%, but then you have 19% of cats with subclinical hypothyroidism where their T4s are normal but their TSHs are increased. And those tend to be temporary, even though they can still be permanent. I mean, it may take some time, but the moral of the story is that you can't ignore that. You got to treat these cats with levothyroxine, and you can't not measure a TSH just because your T4 is normal, because then you're missing out on the cats that have subclinical hypothyroidism. We are really scratching the surface, but I think that we've really changed the outlook on how we treat these guys. So no question, I-131 is the gold standard treatment for hyperthyroidism. And the other important thing that I wanted to mention is that when I was trained, we were trained of starting these cats that were hyperthyroid on methimazole to look at their kidney function. And then if you unmask kidney disease, then you wouldn't do I-131. We know now that there's no reason for this, because a poorly treated cat or an overtreated cat is just as bad for the kidney. So meaning that if you give them methimazole and you overtreat them with methimazole, then you worsen kidney function. If you undertreat them with methimazole, that's also bad for the kidneys, because it access blood flow and pressures and exposing the body or the kidneys and the glomerulus to increased glomerular pressure, etc. So there is no reason to pre-treat these cats with methimazole. And also there are plenty of cats that get methimazole reactions, and there's no reason for that, especially if you're doing the individualized I-131 treatment where you're minimizing the chances of hypothyroidism post I-131. So I say this with the caveat that you're doing an appropriate I-131 treatment. And before we had the excuse that we just didn't know how to dose these cats, but now we do. So yet one more reason to treat these cats appropriately, just like you would a person. You want to treat them with a permanent treatment, with what's going to fix them, with what's going to give them the best possible outcome. That is I-131, no questions asked. I tell owners that I get two sets of patients. I get patients that come in where they're newly diagnosed with their hyperthyroidism and get treated. But I also get patients that have been hyperthyroid for many years, and the T4 has been gradually increasing, methimazole dose has been gradually increasing to the point where it doesn't matter how much they increase the methimazole dose, the T4 remains very high. And then months into this, they come to see me. And these cats, unfortunately, they have a much more severe hyperthyroidism. Oftentimes they have this transition between benign hyperthyroidism and thyroid carcinoma if they don't already have a thyroid carcinoma. And that means a much higher I-131 dose, lower success rate, because the success rate with benign hyperthyroidism is 96% versus with thyroid carcinoma maybe 75%. There are not a lot of studies out there, but you know it's lower than benign. They're going to need a much higher dose, and that means that they're going to stay for a much longer period of time in the hospital, which increases chances of issues because they have been poorly controlled, so they've had uncontrolled hyperthyroidism for a long time, and now they're coming for I-131 because you don't have any other recourse. But it would have been so much better to have treated this cat many years ago when they were initially diagnosed. And it's hard to really know what the real story was, but there are plenty of people that tell me that I-131 was never recommended or was mentioned, and they regret not having done it sooner. Never know if that was real or not, but that just tells us that at the very least we need to be more transparent about permanently treating these cats. I oftentimes get asked, is my cat a good candidate or whatnot? And the truth is, there's no bad candidate. The only bad candidate is that patient that has some terminal illness where it wouldn't justify why treat them with I-131 if they're not going to live very long because of this other terminal illness. But other than that, there's no reason not to do I-131, and more importantly, there's no reason nowadays not to do the appropriate I-131 therapy, which is the individualized protocol. This will give you the best possible outcome, and it's not just doing that, but doing appropriate monitoring afterwards. That's equally important. That's I-131 treatment in a nutshell. The last thing I wanted to mention is radiation safety. When you treat these guys, every state has different rules and laws and regulation, so you need to check with whoever's treating your cat and the state that you're in and what their license says. For us, what we tell owners is that, our patients will stay until they're below a certain level of radiation. And once they go home, to limit physical contact for 15 minutes a day for the first 2 weeks, and then 30 minutes a day for the following 2 weeks, and then no co-sleeping for 9 weeks. We also recommend keeping them in a separate bedroom. And the whole reason behind that is that most of the radiation gets excreted through bodily fluids. And so if your cat jumps on a counter and then jumps off, the radiation goes with your cat. But if your cat decides to throw up or urinate or defecate on the counter, now the counter is contaminated or the floor is contaminated, and that radiation will dissipate. It will just take 3 months for that to occur. So having a controlled environment will help you with that. You can either use a flushable litter and flush it every day for the first 30 days, and then you're done. Or collect a litter, and if you're collecting the litter, you collect it in a little bag, then you put it in a bigger bag, and you keep doing that for the first 30 days, and you close that main bag, and you let it sit for another 60 days before putting out for the garbage company to take it, because that will be the time that it will take for that radiation to dissipate. And then the last thing, which is kind of a newer thing, no co-sleeping for the first 9 weeks after going home. And the thought is that even though after 4 weeks you really don't have virtually any radiation in the thyroid gland, you still have very minute amounts. And if your cat were to sleep right next to your head for 8-10 hours straight, then you may get a little bit of an uptake. So that's what we're trying to prevent with that. So it's really not a big deal. The whole idea is, again, to prevent yourself from getting any extra radiation that you don't need to. It's just like if you don't need to take an x-ray, if you don't need to ride a plane, you don't want to do that because you're limiting your radiation exposure over your lifetime, and that's important. I read an article recently that says that in human medicine, it takes 17 years for something to be proven, to be translated into clinical practice. Until a few years ago, we could have said we don't know the ideal way of treating cats with I-131. We didn't know what the appropriate dose is. We can no longer say that. We know a lot more than we did, and we know the importance of maintaining euthyroid status, meaning normal thyroid function. And in fact, we're able to do that with much lower I-131 doses than we used to think of. There are some conventional treatments that use 5 millicuries, and there are cats that They only need 1.3 millicuries in order to be cured from their hyperthyroidism. So we want to make sure that we give every cat the best dose possible according to what we know. And that's the best way of doing that. Hope you find that useful, and I'll see you next time. Thank you.